Now just I will go directly to my topic, CT dosimetry and biological effects of ionizing radiation. As you know, radiation always has risk and benefit. And our task in medical applications is to maximize the benefit while reducing the risk. This is the main issue, because always we have formula, very good image quality or very high image quality. That means very high radiation dose. This is the current formula. Scientists and engineers try it hard to get this formula to obtain or to provide very high image quality with less radiation dose. That means by developing very sensitive detectors and providing very good imaging techniques. So my presentation, I will focus more about the radiation dose for the patients and how we can measure it, different detectors, and how can estimate the radiation risk for the patient from procedures. My presentation layout consists of three main parts: background and radiation detection and dosimetry, radiation exposure in medicine, biological effect, CT dosimetry, challenges and opportunities. I would like to have some small background about radiation. You know that we cannot see radiation. We have limitation in vision. Just we can see part of electromagnetic radiation from 400 nanometers to 700 nanometers. But higher frequencies, we cannot see it, such as ultraviolet radiation and X-rays and gamma rays, and less or radiation with less energy or less energy, such as infrared, also we cannot see it. To detect radiation, we cannot see it, we cannot smell it, so that we need another media that affects seriously by radiation, so we can measure the effect on the matter, so we can find a correlation between the amount of radiation and this effect. Exactly like temperature. We cannot see temperature, just we would like to measure temperature by its effect, whether by thermocouple or by mercury, by any different change in size or volume or any other effects. Also, X-rays can affect the medium by ionization or excitation, thermal effect, or biological effect. This is the way of how to detect radiation. As we are today, we are celebrating the International Day of Radiology. I would like to just to have a specific background regarding this day for 125 years before. You know that Professor William Röntgen was a professor of physics at the University of Würzburg in Germany, and at the same time he was a rector of the university. And just I would like to see to tell you how the chance has a big role in this discovery. As a rector of Würzburg University, he is quite busy. He has no time during the day to do his experiment. And you know, all of you, I think, visited Europe before. During this time, it's fall, and the sunset exactly now in Germany around 5 p.m. At that time, we don't have general electricity for houses and laboratories. You know that this invention after 1910 in New York was the first city public or general electricity for houses and laboratories. With the weather in fall almost cloudy, so that means the lab itself was completely dark or semi-dark at that time. He started to do his experiment in discharge tube or the transmission of cathode rays at that time. And he, by accident, he has a fluorescent screen. He noticed that when he starts his experiment, this screen glows, some kind of glows. And when he stopped his experiment to see what is going on, that glows was fade. Again, he repeated and again. and by his scientific vision, he noticed that this is radiation. He cannot know the type. He didn't understood the type of this radiation, so he gave tentative name for the radiation as X-rays, as we do in mathematics. For any unknown value, we just name it X, and we know that X equals 5 or 10 or 15. Röntgen, this accidental discovery led to extensive research that he characterized. He knew the characteristic of this unknown radiation, and he later knows that this is ionizing radiation, has different characteristics like ionization, excitation, penetration, and chemical effect, biological effect, and thermal effect. All this characterized by radiation by William Röntgen, and he published his paper in 1996 at that time, and he announced his discovery in international conference. Unfortunately, at that time, people, yes, I would like to have to give you a background, because X-rays, the discovery of X-rays made real history. Scientists at that time, or scientists in physics, or people dealing with physics, believe that at that time they reached the end of the physics, because they have Newton laws, they have gravity, they have electromagnetism, and they believe that now we are just reach conclusion of physics. But the discovery of X-rays turned it upside down. And the discovery of X-rays is a basic milestone in the history. It's separate. We have a separate now between modern physics and classical physics. When you speak about classical physics, you speak about physics before the discovery of X-rays. That means Newton's laws, classical mechanics, and electromagnetism. After that, after discovery of X-rays, discovery of radioactivity, special relativistic theory of Einstein, and all this is a part or the backbone of modern physics. I would like to say that in this brief introduction, Röntgen, in spite he was very busy as a rector of university, never give up experimental of his experimental work. That means all of us, we have to do research as much as we can. As much as we can succeed. Okay. So thank you for Mr. Röntgen. He gave us opportunity to have a very good profession. We are proud to be technologists and medical physicists and work in this field to serve the humanity. We start always with the very basic things. Definition of radiation. We define radiation as production and emission of energy in a form of electromagnetic waves or fast moving subparticles. As you know, now we divided radiation into two parts: electromagnetic radiation and particles. In this session, we are not going to deal with particles, just we are going to speak about electromagnetic radiation, because as is CT scan or X-rays in medical imaging. Electromagnetic radiation, we have two kinds of electromagnetic radiation: ionizing radiation and non-ionizing radiation. You know that all particles are ionizing radiation. Electromagnetic radiation has two parts: ionizing and non-ionizing. We have a specific threshold that the energy equal 13.6 electron volt. This is the energy required to ionize hydrogen atom. The hydrogen atom is the least atom that has the less binding energy. So if radiation can ionize hydrogen, that means this is ionizing radiation. If the radiation cannot ionize hydrogen atom, that means this is non-ionizing radiation. For that, X-rays and gamma rays are part of ultraviolet radiation is considered ionizing radiation, and the rest from visible light till radio wave. This is non-ionizing radiation and has different approach and different effect. Okay, when we would like to measure radiation, we will ask ourselves what do we want to know about the radiation? Are we interested in energy or position? What is come from, or how many particles or the photons, or how much the photons? This because we'll decide the type of detector we are going to use it. Nowadays we have almost 19 or 20 type of particles, and on the type of energy, or whether we would like to measure the position or to decide position, or how many, or just detect the presence of radiation. So this is the major difference between detector and dosimeter. Detector just to detect the presence of radiation. Dosimeter to quantify the energy, the amount of radiation, position, and how much and how many. If we would like, we are interested, is details, dosimeter and a spectrometer. If just we would like to check the presence of radiation, this is just a very simple approach for radiation detection. The radiation dosimeter, we speak about energy resolution, spatial resolution, sensitivity, counting speed. In general, we care about radiation management, measurement task, radiation protection, radiation search. Radiation search, just like Geiger-Müller count, just to detect the presence of ionizing radiation in a specific area in the lab or in other places. I have just very simple, quick comparison. You can see here, this is gamma rays, beta rays, alpha rays, specific ionization, because ionization depends on the charge and mass. If radiation has higher charge and big mass, bigger mass, so that means has highest specific ionization. Radiation with less mass has less specific ionization yield. Gamma rays has a specific ionization from 5 to 8, depends on energy, while beta rays have 10 times specific ionization compared to the X-rays, while alpha rays has 10,000 times higher specific ionization. For that, the biological effect of alpha rays and gamma and beta rays are always highest compared to X-rays. This is fortunately because we are using X-rays for medical imaging. For that, the biological effect resulted from medical exposure is very low. It's very low because X-rays has very low specific ionization factor, because X-rays doesn't mass or charge. For that, the yield or the biological effect resulted from radiation exposure is very low compared to beta rays and alpha rays. And you know that alpha rays never used in medical applications. Just we have some experimental work nowadays for radiation therapy, or for diagnostic approach. No, beta rays, yes, can be used for diagnostic purposes in PET-CT, in PET, for positron emission tomography. We use kind of beta rays. This is very important issue because we are going to compare the biological effect for X-rays and gamma rays and beta rays and alpha rays. As I said before, in order to detect radiation, we have to search for material, a specific material that give us a specific effect. For this presentation, I will not speak, as I said, about alpha or beta rays. We just will speak about photons. We can detect photons either directly or indirectly. Directly by by producing direct charge, electrical charge from gas detectors or semiconductor detectors. Always direct detectors are very efficient in conversion the energy from X-rays to electrical signal. While we have scintillator detectors, we change the energy of X-rays to the visible light, and then through photocathode we change this to electrons, and then photomultiplier tube, as you know, the rest of the story. Scintillators nowadays are not used in many clinical applications, except nuclear medicine, but in CT scan now mainly we use semiconductor detectors because it has efficiency up to 100%. Back to history also, we studied at secondary schools and intermediate schools that how we can detect radiation by electroscope. It's easy. We have two gold leaves. It's a specific part when we X-rays pass through this area, ionized air, and then discharge this part, or photographic plate also in the past. During the first days of radiation discovery and be used for radiation detection. Just we put a film in a specific place, and just after developing this film, we can detect whether it is a radiation or not. You know that still films are used for radiation detection and dosimetry also. Also, spin thyroscope also as a very simple detectors used for radioactivity. This was the beginning of radiation detection at the past, and then later on developed such sophisticated ionization chambers for detection, such as Geiger, Muller, and other kind of detectors. For radiation detectors, we can classify it into 5 or 4 detectors: counters, number of interactions, source mode, spectrometers like multi-channel analyzers give us very specific details regarding the type of radiation, the type of radionuclide, type of water, very huge details about radionuclides. Dosimetry just determine us about how much radiation dose by the patient or by staff. And imaging system also you have these detectors. Our intention is to convert this into gray scale in order to evaluate the energy and the intensity of radiation. As you know that it's just X-ray image is a shaded image. According to the amount of transmission of radiation to the other side, we can decide whether it is hard tissue or soft tissues. And you know that X-ray is basically transmission imaging. I will speak in this slide about radiation dose quantities. I know that many people are scared about radiation dose quantities and units, but it is very specifically we have to understand this quantities and units, because for our radiation protection and measurements and patient safety depends on our understanding of these units. So the first quantity was exposure. Exposure can be defined very simple: ability of X-rays or gamma rays to ionize air. So ability of X-rays or gamma rays to ionize air. That means exposure only deal with air, radiation interaction air, no other medium, just in air. Absorbed dose is another quantity that used to specify the amount of radiation transmitted, energy transmitted from radiation to the medium. So we are speaking about radiation transmitted from radiation to a medium. Exposure, just ability of X-ray or gamma rays to ionize air. We cannot do anything about exposure. We are here about amount of energy transmitted, because we are caring about the biological effect. So now we knew that there are some conversion factors. We can convert exposure to absorb dose. Then you know that different radiation, as we saw before, different radiation has different specific ionization, like alpha rays and beta rays and gamma rays, so that absorbed dose is not enough to describe the biological effect of radiation. We have to consider radiation weighting factor. If we add radiation or multiplied absorbed dose by a specific radiation weighting factor, in that case, we will obtain equivalent dose. Equivalent dose, that means we can have understanding of the radiation effect according to the type of radiation. This is the third step. The fourth step, you know that human body has different radiation sensitivity. I mean, when I made an X-ray image for chest, and another X-ray for abdomen, and another X-ray for the legs, for example, or for the brain, and the absorbed dose is the same, the effective dose will be different, because the sensitive organs always at the pelvis, for example, and for the chest, for the female exactly. If sensitive organ within the primary field, that means we can expect a higher effective dose. But if we made CT scan for the brain, that means we expect very low effective dose, regardless the dose is very high. The absorbed dose is high, but the effective dose is very low. From effective dose, we can estimate the radiation risk or the projected risk for the radiation. From effective dose, we can collect a collective dose. We can, for a general population in a specific area or a specific country, how much population receive collective dose from medical exposure. And you know that this is very important, because in medical imaging, we have very simple principle. If we have very small doses for large number of population, at the end we will have the same effect as we have limited number of population receive very high doses. So that means the projected cancer risk is the same, whether we have just 100,000 people receive each 100 receiver, or we have 20 million population received each receiver. The biological effect is the same. I mean, at the end of the day, we will have the same cancer incidence for those populations, regardless of the amount of radiation. For that, we care very much about the radiation dose reduction. And for example, in the United States nowadays, people believe that 2% of radiation of cancer in the United States as a result of medical exposure. 2%. 2%, if you multiply this number by number of cancer incidents in the United States, that means 30,000 cancer due to ionizing radiation, and the majority of this due to CT scan. So it is very, very high number really, and we are facing real problem. All of us in our private discussion, cancer incidence is increasing. Yes, it's increasing because our approach to ionizing radiation is different. We are exposed to different radiation, different chemicals, different poisons that can cause radiation defects. For exposure is physical quantity, that means it can be measured. Effective dose is radiation protection quantity. We have another operation quantities, because these quantities are specifically designed to measure the radiation dose according to the specific application. For CT scan, for example, we have CTDI, we have DLP. Recently, the new name CT air Kerma index, CT air Kerma length product. These are used in clinical practice as those descriptors to have better understanding of radiation exposure. It is different from entrance surface dose or entrance surface air kernel. This is a very important figure from exposure, CTDI 100. We convert by multiplying this value by a specific conversion factor to obtain CTDI weighted. And then when we multiply CTDI weighted divided by pitch, pitch, we will obtain CTDI volume. When we multiply the CTDI volume by scan length, we will obtain ALP, dose per procedure. We have a specific conversion factor to obtain effective dose. This is very important because we cannot compare CTDI by dose, for example, for chest X-rays, because we measure another operation quantities, entrance surface dose. For mammography, we use average granular dose. For fluoroscopy, we use peak skin dose or dose area product as those descriptors. We cannot compare these different radiation quantities unless we have to convert all these quantities to effective dose. When we convert it to effective dose, so we can easily compare the dose values and expect the projected radiation risk from this procedure. This is the main dosimeters. We have specific characteristics for radiation detectors: high spatial resolution, high stability, real time, linear, and vivo measurements. If we have this characteristic in such dosimeter, that means it has very good characteristic for communications. In radiation protection, we speak always about radiation risk. You have to compare radiation benefit against radiation. As I said, we have huge benefit from ionizing radiation. It is imperative need. You have to use it in clinical practice, but at the same time, you can use it very safely. Many people believe that radiation is risky for patient and staff. Yes, if we use it unwisely. But if we use ionizing radiation wisely, the risk is less than the risk of drivers or any other jobs in our current lives. Radiation effect, in general, we can classify it into stochastic effect or tissue reactions, stochastic effects or cancer effect. That means radiation can induce radiation cancer. We can estimate this by dose. Tissue reaction or deterministic effect. This is always induced radiation injuries, such as cataracts or skin reddenings. Like this patient undergone cardiac catheterization, and the other patient undergone CT perfusion. So it is easy nowadays to have such skin reddening or skin reaction during current era of medical imaging. We can ask ourselves why this happened right now. This happened because now we have very powerful X-rays. The amount of X-rays is very huge. You remember that the first ever X-rays provided by Professor Röntgen for his wife hand took 15 minutes to obtain enough density to form an image. So he irradiated his wife hand for 15 minutes to obtain that image. But nowadays it is half second is enough to generate some lethal damage or some high damage for the patient. Why? Because nowadays we have very powerful X-ray tubes. If we didn't use it wisely, it's easy to have an accident. I use always to describe for the student, if I have a car, I drive a car with a speed of 10 kilometer per hour. It's easy to control this car without any accident. What if I drive my car with a speed of 180 kilometers per hour? I cannot control my car, even very tiny motion or an accidental motion, and lose my life from that car. Nowadays is the same. In the past, we have 15 minutes. If I increase it 16 minutes, it is nothing. It is nothing, just 1/15. I have no any side effect. But nowadays, I have very powerful radiation. I have half a second. If I increase just 50 seconds, that means I double radiation risk for the patient. Nowadays, unfortunately, many people, especially medical doctors, believe that scan time is very short. That means the dose is less. No. That means you know that we have a proportional relation between time and tube current. Tube current, that means number of photons. Time and current are proportional. If I reduce the time, that means I increase the current. So the amount of X-rays is very huge, and in that case, we have to control radiation very, very carefully nowadays. Just I will focus specifically for radiation CT perfusion. As you know, CT perfusion, we use fixed table, not rotate at current other investigations, because we would like to image or to scan a specific volume. In CT perfusion, we have specific area. We will measure the radiation or the blood flow in that area. We always, the patient undergone 50 to 30 CT scan at the same area, so that it is easy to have such kind of radiation effect for those people. They undergo CT perfusion, and they reach 2 grays of radiation because they miscalibrate the CT machine, and they use the wrong parameters, not optimized at all. For that, we can easily see such a kind of effect for current patients. Although this effect reduced or eliminated for 100 years almost, this effect for patients was reduced till 1910, I think. After that, no effects except in radiation therapy. But nowadays, because we have very powerful CT machines, powerful X-ray machines, now we have such a kind of this effect. We have to deal with it very wisely. Also, this some kind of accidents. This child undergone 150 CT scan because for the miscalibration of CT scan, the setting was for CT perfusion. You would like just to undergo brain CT scan. The technologist missed that and undergone 150 CT scan for a child less than 2 years old. This is some accident happened in United States for CT perfusion, and this is just for 2 years old child. This is erythema as a result of radiation exposure, excessive radiation exposure for patient undergone CT perfusion. So CT is a very risky tool for deterministic effect and cancer effect also. As I say, CT scan induce almost 30,000 annually radiation for cancers. Not mean immediately. I mean our harvest from cancer, not now, after latent period, after 20 years, those people undergone X-rays in 2020 will have a cancer risk after 20 years or 15 years, according to radiation sensitivity, radiation irradiated organ, and the age of the patient. Here, if we compare different radiation sources, we have just CT before radiation therapy. If we compare bone scan and other even annual background, CT had the highest radiation dose. compared to other medical sources. It is important to note that we know that female always very sensitive to radiation than males by factor of 1.6, I think, in all ages. For young age, the gap is very big, but at elderly people, still the gap, but with minimal change. The threshold is around 40 years old, and then start to decrease annually by increasing the age. Very important questions. What about our regulation for radiation protection? Regulation for radiation protection always based on female sensitivity in order to protect females from biological effect of ionizing radiation, while to keep also male safe from unexpected event due to radiation effect. You know that due to this fact, scientists build their assumptions about probability of radiation risk. For that, they state annual radiation dose limit for workers is 20 millisievert, for Tyranny 6 millisievert, for Banana Republic is 1 millisievert. This is 6 average. We have check the radiation sensitivity for male and radiation sensitivity for female and divided by 2. So for that, we protect both male and female. Why they didn't make radiation protection rules for female and males? Because to avoid discrimination in work environment. Because if they said like that, employers, they will say that they are not going to employ any female because they have less radiation dose limits. We prefer males. For that, scientists in different countries read the International Energy Agency. They have this approach to protect both male and female and to avoid discrimination in work environment. Patients in CT dosimetry, yes, I would explain some relation between different dose values. This is CT exposure parameters, X-ray tube voltage, X-ray tube current, scan time, slide thickness, or emissions. This controlled always by operators. Sometimes we can use automatic exposure control to control all this based on patient imaging protocol. In CT scan, as you know, radiation, the X-ray tube rotates around the patient. So we have different dose descriptors compared to chest X-rays or conventional radiography or fluoroscopy or others. It is important to note that CT dose index was introduced in 1991, while CT was invented in 1971. So for 10 years, we don't have those descriptors for CT scan. Still, we have very serious shortage in estimation of radiation dose based on those descriptors for CTDI, CTDI volume, and DLP, because the protocol, the image protocol is quite different from conventional imaging. I will not go through the physics. It is mid of day and it is hard to speak about some equations about physics. But in general, this is how we can measure CTDI. This is the radiation exposure using a specific phantom to have one slice. When we speak about CTDI, that means we are speak about radiation dose per slice. Okay, CTDI volume, CTDI weighted, CTDI vol 100. It is radiation dose per slice. Okay, when we speak about DLP, we speak about the radiation dose per procedure. So we have two kinds of descriptors, per slice and per procedure. Because radiation dose is different, we irradiate the patient from outside to inside because it is external. Outer layers of the patient receive highest radiation dose. Internal parts of the patient receive less radiation dose due to ionizing radiation attenuation. For that, we need to find a kind of weight to have an average radiation dose. We take the average, the 1/3 of radiation at the peripheral and 2/3 of radiation at the center. From that, we obtain the radiation dose weighted for CTDI in order to have a relevant or accurate estimation of radiation dose per slice. This is the relation. If we irradiate the patient, outer dose is 20 and at the center is 10. In that case, we would like to have a kind of weight. In physics, we can say it, or a kind of normalization. For brain, we don't need that because the brain size is very small, so we irradiate the brain homogeneously. But we speak about CTDI weighted when we speak about patient trunk irradiation, patient trunk, chest and abdomen. CTDI volume obtained by dividing CTDI weighted by the pitch. So the pitch has inverse relation with CTDI volume. If we increase the pitch, we reduce the CTDI volume. For that, in medical imaging, if we would like to reduce radiation dose, one method is to increase radiation, to increase the pitch. But increasing the pitch, you know that reduces the image quality. For that, as I said at the beginning of this presentation, any action reduce the patient dose, also reduce the image quality. For that, we are seeking always about the optimum radiation dose. For CT perfusion, as we know that we don't pitch, we have a fixed tube, a fixed table. The radiation dose can be estimated by peak dose by J rotation, number of rotations. If we have 50 rotations, so we multiply this by radiation dose to obtain total dose for the skin, for specific organ. If this is scan length, we multiply CTDI volume by scan length to have DLP or dose length product, and the unit is milligray per times centimeter. Milligray times, this is CTDI volume multiplied by scan length. It is very essential to differentiate between different CT quantities and units. CT dose descriptors, as I said, when we speak about CTDI, that means this is just about radiation dose per slice. When we speak about CTDI 100, also exposure per radiation per slice. When we speak about DLP, dose length product, that means radiation dose per examination. We can use DLP multiplying DLP by a specific correction factor and the effective dose per procedure. In our system, current system, any radiological system, according to the ISO recommendations, any radiation or any CT or system manufactured after 2008 has displays radiation dose for patient. Okay, so it is easy nowadays for all medical equipment. You can easily notice CTDI weighted DLP, CTDI volume procedures, in addition to those other exposure parameters, kV, milliair, and second. In the left hand here about the conversion factors, we use it for to convert DLP to effective dose. You can see here a very small conversion factor for head and neck and head, and we have very high conversion factor for the trunk, because trunk has very sensitive organs while the brain has less sensitive organs, because you know that neurological tissues has radio resistant phenomena. Okay, now we are aware about radiation protection, about how to measure radiation dose in CT scan and dose descriptors. You know that classification, optimization, and dose limits. In practice, this is IEA data shows that 20 to 50% of medical exposure unjustified. That means people or medical doctors might use unjustified requested procedures. This is one thing. Another thing, we knew that optimization can bring down patient doses about 50%. So if we have justified medical exposure, that means we will reduce at least 75% of the radiation dose nowadays. 50% we can use alternative medical like ultrasound or conventional radiography or MRI. And optimization we can use. If we spoke in numbers, I said at the beginning of this presentation, in the United States, we have almost 30,000 cancers due to medical exposure. That means by optimization, we can reduce this number to 50% by 15,000. And after, if we make clear justification, we reduce this number again to 50%. We will have just 7,500 cancer instead of 30,000 cancer. This is huge achievement. You can imagine how many resources we need to treat almost 30,000 cancer patients from cancer can be avoidable. For that, radiation protection in CT is very important, especially for young females. For young females, we have to take care before ordering radiation because they have less radiation sensitivity, and breast cancer has high incidence probability. For example, if you just made CT for young female, you increase her probability of cancer breast 10 times. This is very original data, and for that we need better optimization and justification for young females. Before we go to the last of this session, I would like just to give you a background about how our international radiation protection system works. We have two international organizations, UNSCARE, United Nations Scientific Committee on Effect of Atomic Radiation, and we have International Committee on Radiation Protection. UNSCARE obtain data from member of states. This is United Nations Organizational Committee, and reports about level of radiation exposure from member of states. Each country required to submit data regarding radiation source in their country and collective doses for general population. ICRP collects its data from scientific publications. I mean, you publish a paper. This paper always screened by specific groups from ICRP, and then collect this data and make a recommendation. UNSCARE and ICRP make a recommendation for International Atomic Energy Agency. International Atomic Energy Agency make an international guidelines. It is not regulation. It is not rule. It is not mandatory. It is guidelines. It is better to use it. Okay? It is not mandatory. By default, all member states, except United States, adopt the international recommendation or international standard for an International Atomic Energy Agency. United States has different approach, different rules for radiation protection. You know that we have 20 millisievert for radiation worker, but in the United States still they have 50 millisievert radiation workers and other different approach for radiation protection. So this is international from UNSCARE, ICRP, International Atomic Energy Agency, international standards, so then adopted in national level, different countries. For different countries, we have laws of radiation protection. This is always adopted by the highest body in the country, by the king or by the parliament, and then radiation protection body in the country make regulations for this law, and each department has a code of practice in order to fulfill the criteria of radiation protection for different medical exposure. I mean, when we use thyroid shield, when we use island shield, when we protect the gonads for the child, this is the code of practice for the protection for personal level. I mean, in patient level. We have different challenges for radiation protection nowadays. We have more scanners, we have quicker to use, we have more request forms, we have unaware medical practitioners most of the time. I mean, we have medical doctors always focus on clinical aspects. We would like also from them to focus also in radiation protection and safety, not only in clinical outcome of the patient, regardless of the amount of radiation exposed to this patient. This is very serious, and we have to implement different radiation training hours. For example, for IEA recommends that each medical doctors, at least he has 10 to 30 radiation protection training courses. If radiation protection, if the medical doctors have a culture of radiation protection, that means at least we reduce, as I said before, 25% unjustified medical exposure. Before the last, we have unjustified exposure. Yes. We have wrong patients. Yes, it happens always in the medical imaging departments. We have wrong body parts. Always happens. Lack of optimization. Yes. Lack of calibration. Yes, also. Lack of quality assurance. Lack of establishment of diagnostic reference level. Always. This is the current situation in medical imaging. Fortunately, my colleague, Dr. Isam Tom, will speak about how to reduce patient dose during CT scan. This is very important. He will answer for us these different questions about how to justify, how to use, how to make effective quality assurance program, how to implement diagnostic reference level in order to reduce radiation risk. We have new always technology, new exams. You know that many exams now, in the past we use radiography like CT urography now replace IVU, and different clinical examinations now, instead of using conventional X-rays, now we use a CT scan, but the radiation risk is very high. To have a balance in the future, you remember the point was 1971. Dual slice CT scan was 91, and in 2013 we have 640 CT detectors or CT slices. Now we are waiting the development of 1,280 CT slices. You know that our main challenge, we have a lot of information from the patients. Even radiologists cannot look at 640 patients in order to decide pathology. So that technology is beyond human capabilities in order to diagnose or to get accurate diagnosis. At the end, we would like to confirm that safety is first. Safety for COVID-19, for infection in the radiological department, safety against ionizing radiation for patient and staff. It is our top priority in order to have maximum benefit while reducing radiation risk. Thank you very much for your time, for listening to my presentation. If you have any questions, you can just send for me using this email, or can ask directly right now. Thank you very much.